My real motivation in bringing Bill here with me is to understand how you work with patients who are facing mortality. We see many patients who are distressed. They're not all worried about death, but many are. They tend to have many layers of concern. So the core concern generally is mortality. And oncologists tend to see the other side when patients are striving for life, and they may or may not be interested in bringing up mortality or considering mortality, but it always comes up. As oncologists, we struggle to bring it up, when to bring it up, and how to bring it up. I know through working with Bill and other psycho-oncologists that the answer always depends. This type of learning is truly experiential, and there's not a singular answer necessarily, but I'm hoping that we might distill the key issues and components that go into effectively reaching patients on this topic. That is truly the essence of MCP, meaning-centered therapy, I think. And most oncologists have a tremendous repertoire of experience to draw from when seeing patients who are encountering mortality, but may not have had or received guidance on their approach. Like the old saying that practice doesn't make perfect, but perfect practice does. There's really no such thing as perfection here, but there is a sort of good enough phenomenon where one reaches a feeling of being competent. One of the issues is that we can tend to overcorrect sometimes. Many patients these days get the message that the teams want them to be prepared, but constantly bringing it up can have an off-putting effect, like treating them as if they've already succumbed to the disease. Patients want more than anything an acknowledgement of their presence and existence. How, Bill, do we do this delicate dance? I'm thinking of a real case that I saw at Memorial Sloan Kettering. And I went out to my attending and I said, they consulted us for depression, but I don't think this patient is depressed. And my attending at the time said, well, Daniel, look in the chart, see how many times this patient has seen the oncologist. And so it was many times. Let's say that because the patient's dying, I was a bit shaken up by the experience. What would you say to me, Bill? How would you guide me on working with this patient?
I would probably actually go in and see the patient with you, and I would try to engage the patient in a discussion with you present and show you how to do things. And it boils down to a couple of very basic, simple things. Um, One that is critical for both oncologists and for psycho-oncologists is what we try to do in every encounter is have a basic human conversation. And what do I mean by that? I mean through either the way we convey ourselves, what we might ask about, how we might start engaging in things. Want to convey the way we sit, the way we stand, the nonverbal and verbal cues that are given. What we want to do is to convey the message that you and I, patient and a physician, we're both human beings. We're both in the same existential boat. We're both mortal. We both have the same existential concerns. And the only difference between you and me is time and knowledge. It's your time to be sitting in the bed or in the hospital or sitting across from the oncologist. My time will probably come at some point. And knowledge, what it is that is threatening your mortality in a more immediate kind of sense. You can actually see what might get you. I may not have that knowledge yet, but I have some knowledge about cancer and treatment, medical oncology knowledge, psychiatric psychology knowledge. I have some knowledge that may be of some help to you. So the first thing is to start to establish and engage in a human conversation.
Essentially, we're two human beings sitting together, facing mortality, essentially.
Right. There's not much difference between us in terms of the fact that we're both mortal. And so we have this in common. For us to be able to talk about existential concerns, mortality is not unreasonable. You have them, I have them too. So we can talk about them. There are boundaries in terms of how much you want to reveal about things, about yourself and all that. But it's perfectly okay to be somewhat revealing in the sense of I worry about dying too, or I think about death as well. As an oncologist, you don't necessarily want to push the conversation of death and dying and how you're feeling about that. How do you feel about the fact that you're dying? Or you want
Hmm.
the door to be open for the patient to feel welcome about talking about their fears. You and I walk in the room is after trying to get to know the person as a person a little bit. I ask them about their family and what they do for a living and whether they watch Jeopardy or things like that, and then start to talk to them about real serious stuff. I might ask them directly, are you frightened of dying? Do you think about death? Things like that. And I might go straight forward. And it's not my responsibility to keep them alive. And the expectation on the part of the patient is not to be the person who's going to perform the miracle to keep them alive. We're all kind of dealing with uncertain futures. We don't know what's going to happen.
Hmm.
And a really favorite philosopher of mine, a guy named Jacques Derrida, talked about two kinds of future, the certain future and the uncertain future. And the certain future he described as being universal, mundane, mediocre, completely non-unique. Everybody has the same certain future. You're born, you live and die. There's nothing you can do about it. The fact of the matter is we're all living pretty much uncertain futures. We don't know exactly what's going to happen. There's a course that lays it out. We don't know exactly how long, you know, what are the treatments that would be most helpful, what steps to take, where to get my care, who to trust my care to. Do I take this treatment or that treatment? How long will I live? How will I die? How do I want to spend my time and all that? So the uncertain future really is the only kind of future in which there's a leeway, there's room. There, the uncertain future is the only kind of future in which you have the possibility of participating in creating that future through the choices that you make. I know many of my oncology colleagues are very frightened of giving patients false hope. I can understand not wanting to give patients a false hope that they will be cured, for instance. But the ability to be able to maintain hope that a person can create a future in which their life has some meaning, in which they're able to retain some elements of the essence of who they are so that life is worthwhile, worth living while you're going through the treatment. Sometimes I actually say this to patients. They talk to me about the fear of dying, and I actually say, you've got a bigger problem than dying. I said, your problem is how to live until you die. You may die in 3 months, you may die in a year, you may die in 5 years, you may die in 10 years. But in the meantime, you got the problem of how do you live in the face of this illness with the treatments that you have to go through. And so you have a bigger problem than dying. Dying will take care of itself. So your problem is how do I live until I die in the moment? And so that's the real challenge for most patients. And that's really what oncologists are engaged in.
As oncologists, we feel oftentimes it's our responsibility that we take up willingly, that we are providing treatments, and the holy grail, of course, is survival, but also quality of life. And we enhance that through our treatments. And we can lose sight of the living that has to go on during the time someone's getting treatment. And sometimes reminding people, like you said, of death will take care of itself. I mean, everyone knows that, but actually to be reminded of that, people forget to live. People forget that that is really what it is about, because they get attached and fixated on the treatment, on these things that ultimately they don't have too much control over, and it causes a tremendous amount of distress. It's the thing that they've wanted to run away from for so long, and then it finally happens. There can almost be this sense of relief.
When patients are dealing with this uncertain future and making choices to create this future, it's really helpful. That's why it's so important for oncologists to partner with patients around the choices in their treatment and their care. Because what really is taking place for patients in this process of creating this future. How do you want to live with cancer? Most patients want to live a longer life. They want to live a life of quality with some prolonged periods of health, right? They're going to be given choices of treatments, right? And so it's really helpful for the oncologist to partner with the patient in helping them make these choices, because those are the choices that are going to help them create a future. What kind of future do you want? That's part of the process of creating this future.
It's interesting because one thing I've been thinking as you were talking was about the way that oncologists make decisions around treatments, and some of them are very clear. Many times, especially orphan diseases, the treatments aren't clear. That often creates such distress in the patient. You, as the oncologist, interacting with your patient for whom you've chosen a treatment, when that choice has some ambiguity around it, it's very natural to have a sense of guilt or regret, and how those are obviously our feelings, not the patient's feelings. And that is often, I think, what makes some of these end of life conversations difficult for oncologists. I think it's much less difficult when the treatment was very clear.
The primary emotion that we end up seeing as psychiatrists or as psychologists or as oncologists, we tend to see fear, right? And fear takes up all the oxygen in the room. And we think that fear is the only emotion of death, related to death. And emotions and the whole idea of death and the whole idea of the emotions related to death are much more complex than we even think. When we're talking about death, we're talking about we're talking about the period of time that leads up to death. How will I die? Will I be in pain? It's the process leading to dying and needing some reassurance that that can be controlled. Our jobs as human beings is to try to, at some point in our lives, when we become aware of our existence, to create a life and to create a who in the world, to become a person. At some point, you learn who you are. And then your job is, in a world in which you are battered by hundreds and thousands of external events and elections and economies and pandemics and things like that, and internal events like illnesses and cancers and things like that, to try to preserve the essence of who you are despite being battered in all these directions. And so your job is to try to sustain and preserve the essence of who you are. You can put up with losing some parts of it if you can accentuate others, right? But at some point, if you completely lose who you are, then that's when people express to you the sense of like it doesn't feel worthwhile existing, right? And so, as much as possible to help patients pursue, and that's part of what where meaning-centered psychotherapy is all about, is trying to help patients sustain that sense of meaning, that life is still meaningful and worth living through utilizing these sources of meaning. But people are concerned about the process of dying and that taking away the chunks of who they are. People are afraid of the actual moment of dying. Will I die in pain? Will I be struggling for air? Will it be painful to die? And then people are concerned about existence. Will I cease to exist? Dying is actually more complex than just one thing. Death is not just one thing. While you're thinking or contemplating about answering which one of those areas you're concerned about, let me just say I'm concerned about all of them.